The broadcast is now starting. All attendees are in listen-only mode.
Thanks everyone for joining. We're going to give everyone a few minutes to get in and then we'll get started. Hello everyone. Thank you for joining our webinar, Maternal Patient Safety, COVID-19 and Beyond. Just wanted to jump on the webcam for a second so you can put a face to our names. My name is Lexi. I'm the marketing manager here at Perigen, and I'm joined by Dr. Alana McGolrick. She's the Chief Nursing Officer, and Karen Kallega, our Client Engagement Executive. We just wanted to let you know that we appreciate you joining us for the webinar. We are thinking of you during these unprecedented times. We're just glad you're here. We hope that we can provide valuable resources to you. At this time, we are going to take down our webcam for bandwidth. Just want to make sure everything rolls smoothly, but enjoy. Alana, I'll go ahead and next slide. We'll get started. So just a little disclaimer, this presentation includes information from various sources. The following studies were not conducted by Perigen. To ask a question during the webinar, just enter your question into the chat box located into the GoToWebinar panel on the right side of the screen. If you wanted to go ahead and try this now, I'd love to see where everyone is calling in from. Go ahead and just type in maybe the state or city you're from. Dr. McGolrick is calling in from California. Karen is calling in from Florida, and I'm here at our headquarters in Cary, North Carolina. Looks like we have Chicago, Dallas, Hanover, Alabama, New Hampshire. Wow, people from everywhere. Washington, Connecticut. I'm glad to have you and glad to see representation across the country. So a little about Perigen. The presentation today is brought today by Perigen. We provide innovative software solutions for over 20 years with a mission of protecting all moms and babies. Before I pass it over to Dr. McGolrick, I just want to say how excited we are about the large enrollment for this webinar. It really demonstrates the passion we all share for maternal patient safety. And again, we also just want to let you know that we are thinking of you during this time, and thank you for all you're doing on the front lines during this pandemic. So our presenter today is Dr. Alana McGolrick. She's the Chief Nursing Officer here at Perigen. With significant perinatal experience, Dr. McGolrick leads Perigen's efforts to expand and enhance product clinical implementation, education, customer outcomes reporting, and publishing. We also have a guest speaker today from our team, Karen Kallega. So she's a clinical engagement executive here at Perigen. She's a clinical subject matter expert for Perigen's perinatal software, and her expertise in obstetric practice, regulations, and hospital operations improves prospective client engagement, adoption, and implementation. And now I'll pass it to Dr. McGolrick for the presentation.
Thank you, Lexi, and welcome everyone. Thank you for joining today's discussion. This PowerPoint will be made available after at the end of the presentation today. So at the conclusion of this program, I have listed 3 objectives that I aim to achieve by the end of our discussion. I hope that you will be able to evaluate us based on these objectives listed here today. So first, let's talk a little bit about the situation that we find ourselves in, especially in the last 9 weeks. Lockdown, shelter in place, social distancing. Today, these are new terms, part of our normal vernacular. We use them without hesitation as if they have been using them forever. My colleagues and I are in different parts of the country and have experienced vastly different forms of lockdown. I live in California. Today, my state and county remain in lockdown, and we are just beginning to approach phase 1 of reopening. It's our 9th week of social distancing. I stand in line on painted dots to enter our local Trader Joe's. I wear a mask in public places, and I cannot see my friends. This is my new norm, full of unknowns, and to be completely transparent, some periods of anxiety when I contemplate the duration that I may have to spend in this current state. Stressful as this may be for me and my family, for our pregnant patients, their journey was abruptly changed. Imagine being unable to attend prenatal visits in person or bring their partner with them to hear the heartbeat. The public health crisis for the pregnant patient means an entirely different new set of rules. The fear of the unknown is prevalent every day. The question is, how can we as professionals create transformed care environments to address what we do know? The current public health pandemic was first identified in China in December of 2018. This rare form of pneumonia did not respond to normal treatment modalities, and if requiring hospitalization, patients were deteriorating quickly. Transmission routes were indeterminate, although respiratory was suspected, and the rate of transmission quickly spiraled worldwide. In March 2020, the World Health Organization declared this a pandemic. With so many unanswered questions, care guidelines continued to be revised from their original recommendations. So what does this mean for the pregnant patient? Although the CDC, World Health Organization, and NIH have rapidly developed guidelines for the obstetric patient, there are many areas of care that remain underdeveloped. Exacerbating this problem is the fact that we have 2 patients to care for, as one is invisible. A very important fact that I love to remind our leadership outside of obstetrics. The general treatment guidelines based upon the non-pregnant patient population do not address the care of a pregnant patient during each trimester. For example, the impact of COVID-19 during the first and second trimester is unknown. The fetal lungs during the first trimester are developing. They also contain the ACE2 cells that have the greatest affinity for the COVID-19 protein. What does that mean for fetal lung development? If mom is infected during the first trimester and the fetus is already exists in a low oxygen environment, how do we improve maternal oxygen environment in order to improve the fetal oxygen environment? Limited research is available, although all the resources that are here were published free by our national organization. Unfortunately, it is changing every day. Our delivering clinicians need to remain informed of the rapidly changing treatment recommendations that are specific to the maternal fetal dyad.
Okay, we're going to start with our first poll question. So I'm going to go ahead and launch that. So, have you seen a significant impact to the hospital staffing as a result of recent events? You can answer on your screen. You can check all that apply. Give everyone a few seconds to answer. Okay, we're going to close this poll. Share. So it looks like staff reallocation, furloughs, layoffs, and cutbacks, followed by more remote staff members and exceeding staff-patient ratios. Seems like the majority have had an impact to staffing. We're going to go ahead and launch the second poll question. This one is more specific to women and children. So, have you seen significant impact to women and children's staffing as a result of the recent event? Please check all that apply. Give everyone a few more seconds to answer. And we'll share those results. Seems like a little less impact in women's and children, but still similar staff reallocation, furloughs, layoffs, cutbacks, followed by exceeding staff-patient ratios and more remote staff members. Okay, I'll pass it back to Dr. McGarry.
Thank you, Lexi. One of the joys of working from home during this lockdown is that the neighborhood dogs like to bark. So I apologize that you will be hearing some dogs barking. So let's look at the significance of what the current public health crisis has with our pregnant patient. Does pregnancy change the clinical picture of COVID-19 or any other disease pathogen that is deemed a pandemic? The simple answer is yes. The pregnant patient experiences many normal physiological changes during pregnancy that make their response to a disease pathogen different. Normal adaptations include hormonal alterations, increased blood volume and cardiac output, a shift in the diaphragm's position, and immune system dysregulation, for example. Additionally, the changing medical complexity of the obstetric patient put them at higher risk. Our patients are diagnosed with complex comorbidities associated with pregnancy, thus negatively impacting the maternal fetal well-being. The pathophysiology of the leading comorbidities, diabetes, hypertension, obesity, and cardiac disease, are greatly underappreciated, especially during this time of pandemic. Currently, the early literature shows that geographic and socioeconomic disparities are widening the gap due to many complex layers of healthcare access, prevalence for comorbidities, and occupational hazards during this time. To date, there does not seem to be any evidence to support vertical transmission. This is of interest to the perinatal community because our patients have several opportunities to share pathogens that are unique to other patients. Why is this important during this health crisis specific to COVID-19? ACE2 cells are present in the placenta, fetal lung, and maternal lung. The maternal patients can pass pathogens to the fetus and newborn vertically or horizontally. This could occur during bonding and breastfeeding. As I stated before, the current research does not support vertical transmission, but all CDC precautions should be taken during breastfeeding by an infected maternal patient to protect her newborn. Something else that's unique to us is our patient care setting. Have you ever been in the position of trying to describe what labor and delivery care setting really is, justifying why you have at least 2 RNs staffed on the unit when you don't have any patients? How about justifying overtime after an emergency delivery? Over the years, I've used the same definition with my target audiences, including the C-suite to the governing boards. Labor and delivery is a unique blend of equal parts: acute care, operating room, and emergency department. Staffing and working in a unit that combines the expertise of all three departments is a beautiful balance of managing risk and patient safety while delivering miracles daily. Not only does the invisible patient set us apart from the rest of the house, but we have many other unique factors that separate us from the norm. In consideration of the current pandemic, we have to look at our increased healthcare worker exposure time. Our patients require our presence at the bedside for longer durations than a non-pregnant patient. This is just a natural part of our role as perinatal staff members, but that also increases our exposure to an indiscriminate pathogen. How do we provide compassionate care during labor or the postpartum stage if we are unable to spend that time at the bedside in a safe manner? Multiple team members. We may have, at certain times, multiple team members in a patient's room throughout their stay. Thoughtful decisions and appropriate care planning are required to ensure that we continue to safely provide care to our patients while minimizing exposure opportunities to both the maternal fetal dyad, the newborn, and of course our staff. Labor and delivery is unpredictable. We all know that a day on labor and delivery cannot be planned out. As a matter of fact, many of us have found humor in well-laid plans, as that will certainly alter the day as soon as we begin our shift. Emergent deliveries. Emergencies happen, and although we can plan and practice, we cannot predict when they will occur. Personally, I don't mind the adrenaline rush, but due to the unpredictability of these emergencies and the speed at which we begin interventions, steps or mistakes can happen. Exposure to both the patient and the staff have the potential to occur. So what precautions can we take? Although our approach to caring for our patients does not need to dramatically change, care plans do need to be assessed to ensure that they meet both the patient's and our caregiver safety requirements. Ensuring that adequate PPE is available for both the staff and patient. Consider that everyone is positive. I'm protecting me, you protect you. Adherence to firmer visitation guidelines that are sensitive to patient needs can reduce unnecessary exposure. Continuous electronic fetal monitoring is paramount to assessing the fetal oxygenation steps. It is really our only clue to fetal well-being at that time. And if the maternal patient's oxygen environment is impacted by COVID or something similar, early warning that the fetus is decompensating would be beneficial to expedite delivery if necessary. How do we address our unique patient population on our blended units without compromising the care we provide? We need to get creative. We are not going back to the way we were, personally or professionally. We must approach this new world with ideas that are impactful and built upon a solid foundation of safe obstetric care supported by our healthcare organization. Debate over nursing theorists have been going on for years, and the decision to choose a care model has not been taken lightly. Unfortunately, sometimes the care model choice is not that of the actual caregivers on the unit. It is made by those that manage the business aspect of the organization. Patient volume, payer mix, and organization image is now part of how we deliver care. We, as perinatal professionals, must begin to think outside of the box and be creative with our approach to maternal care. This takes a coordinated effort to be transformational and lead, or in some cases, catch up with healthcare delivery models that rely on data, technology, and the art of practice. By doing so, we can be successful in approaching safe, quality care for the maternal patient in innovative ways. To define creative care models even further, we need to address building blocks to establish a foundation of innovative approach. Concepts to consider when developing a new approach include maternal and fetal early warning systems, perinatal telemonitoring, and telehealth. In order to build this foundation, innovative concepts need to address maternal patient safety, protection of our bedside staff, and continuity of patient care. This layered approach establishes the levels that healthcare organizations can consider as we approach the new way of providing care to the perinatal patient. The literature shows that early warning systems have been utilized in the non-pregnant patient population for over 2 decades. These studies show that early warning systems can alert the bedside clinician that a patient is developing a worsening condition very early on. The alert criteria based on vital signs are designed to prompt clinical actions in a timely manner. Setting assessment times with specific routine and repeated intervals, or whenever a trigger is found to have been breached, allow for a judicious approach to patient care. Specifically for OB, in 2014, Meyer et al. Reached consensus on physiological parameters for the perinatal patient. These parameters provided the first step towards standardizing the contents of maternal early warning systems. Perigin, with those parameters, built Vigilance, the only automated maternal and fetal early warning system to assist clinicians and to address the rising maternal morbidity and mortality rates.
I'm going to launch our next poll question. So does your facility utilize remote patient monitoring? Examples are cardiac telemetry and EICU. Give everyone a few seconds to answer. So a few more seconds and I'll close the poll. Okay, and a majority do. Now we're going to kind of drill down on that for women's and children's. So does your facility utilize remote patient monitoring for obstetric patients? Excuse the typo on the poll slide. So a few more seconds here. Okay. And the majority said yes. Back to you, Dr. McGarty.
Thank you, Lexi. So this is just a snapshot of our single patient view within Vigilance. Vigilance is not a documentation system. As I said, it is an early warning system. You can see the data is aggregated from your fetal monitor and EMR. It analyzes that data and gives it back to you with actionable notifications and information. The goal is to provide that caregiver with timely notifications that a worsening condition is occurring and that we can potentially avoid delay in care. So building upon the early warning system is the concept of a perinatal telemonitoring unit. Patterned after cardiac tele units, which we all have, perinatal telemonitoring can take on several forms. It involves the remote observation of maternal patients from a physically different location than labor and delivery. The purpose of telemonitoring is to promote timely patient assessment by the bedside clinician in recognition of critical signs and symptoms that a patient's condition is deteriorating, and to increase that opportunity for escalation of that patient's condition. This can be accomplished by simply implementing a remote eye to watch the patient to augment the primary RN's care. Here are some examples of perinatal telemonitoring models. The first example depicts the eye watching patients from a central location within one hospital. The second shows the eye watching multiple sister sites from within one hospital. And the third provides a unique application of telemonitoring. This has the eye at one location, but monitoring patients outside of its own healthcare organization. For example, the eye could monitor critical care facilities, rural hospitals, and birthing centers. Perinatal telemonitoring offers many benefits, including addressing labor and delivery staffing challenges that we may all be experiencing right now, increased surveillance at high-risk patients, a consultative role from a central location, a relationship with maternal fetal clinical expertise that may not be within your own organization. Those of you that accept transfers can anticipate potential patient transfers coming to your door. And of course, early identification of a patient's worsening condition. So here's the view from the eye, and we call this hub. Perigin was the first to offer the automated solution incorporating both maternal and fetal data. Hub acts as a visual patient summary tool. This can be seen at the bedside, from the nurse's station, or from the remote eye, sorting those patients that are at higher risk to the top, drawing your attention to the most critical patients. Finally, to augment remote perinatal telemonitoring, you can have the additional innovative approach to remote monitoring through mobile health. Vigilance and Hub will be supported by mobile communication devices such as cell phones and other smart devices. Transmission of continuous electronic fetal monitoring, vital signs are directed to the mobile devices as they are in the PC workstation. Imagine how easy it would be to update a physician who can review the patient from home or the office. So the final building block for a creative care model includes telehealth. Telehealth is defined as the distribution of health-related services and information via electronic information and through telecommunication technologies. I'm going to pass this over to KK. She's going to continue the presentation and speak a little bit about telehealth.
Hi, this is KK. Thanks everyone for joining us today. And thanks, Alana, for once again providing us with such great content and information. I'm going to speak to you about the promise of telehealth in obstetrics. This might seem like a newer concept to some, but I'm sure if you think about it, you've been exposed to this. I think about like high-risk patients. So you have a high-risk patient who is geographically not close to a hospital or a hospital setting. They go to an office or a clinic close to where they are, and they have a high-risk ultrasound that is being viewed remotely by an MFM perinatologist who conducts the rest of the visit with the patient. And perhaps during this COVID-19 pandemic, you have had some patients that have had their prenatal visits conducted by telehealth. We need to think differently about the delivery of care in the inpatient setting, and importantly, we need women's and children's care to be included in the discussions going forward. Perhaps in the past you've encountered situations where a new process or a new practice is brought to the organization and OB was not included in the conversation. I know that's happened to me. You have the opportunity to be the voice for women and children and to advocate for inclusion in telehealth initiatives at all of your respective facilities. Let's talk about some of the tools that are available to help with this telehealth journey. When I started my own self-education about telehealth, one of the best things I did was get involved with our regional telehealth resource center. There's regional centers across the United States. I'll talk a little bit more about that in a second. I do want to just touch base about different models of telehealth. For example, there's Store and Forward, which I use that first because I believe that everybody on this call has probably been exposed to Store and Forward. So you have a patient, they have either an ultrasound or like a chest x-ray. It's shot, it's sent to, I'm not sure exactly where, it depends on who you contract with. Radiologist reads it and you get a reading back. That is Store and Forward. It's been in place for quite some time. Another model is virtual patient visits, like I just talked about with a perinatologist. I think that's pretty self-explanatory. And then there is remote patient monitoring. And remote patient monitoring is monitoring of physiological parameters. It can happen either in an outpatient setting or in an inpatient setting. In an outpatient setting, think about the CHF patient that's getting blood pressure measurements at home, the diabetic getting glucose measuring at home, outpatient remote patient monitoring. Inpatient is what Alana already discussed, EICU, cardiac telemetry, cameras in the patient's room, fetal monitoring. Those are all inpatient remote patient monitoring. When you look at the different delivery models of telehealth, Perigin's Vigilance solution falls into the remote patient monitoring category. So if we look at the slide, up here you have the National Consortium of Telehealth Resource Centers. If you were to click on the link, it would take you to the home page, which has an interactive map. The interactive map divides it up to the regions. You'd click on your state and you would get to your own regional resource center. Those websites have a plethora of information about telehealth education, all the different models that I just talked about. And also there's information about grants that are available. The Center for Connected Health Policy website is the website that actually has the aggregation of all the information about legislative issues connected to telehealth. You'll find information about reimbursement legislation, and they do drill down to state specific. Licensure and cross-licensure compacts, that's all available on this website for Connected Health Policy. Lastly, there is a current telehealth funding opportunity, an FCC grant to support the rapid expansion of telehealth. I have the website right here for you. If you wanted to see that application of the grant, they have earmarked $200 million to provide immediate assistance. We at Perigen are working with several partners with their application for their grant. We're helping them to compose content for OB remote patient monitoring services at their facility. I'd like to take a minute and revisit Vigilance. A reminder, this is not a documentation system or an OB census board. This is the Vigilance solution at work. It's a software overlay that functions with the systems you already have in place. So whatever you have in place for your medical record, your EMR, and your surveillance system, that stays, and this overlays it. And what we do is gather information from your existing systems, process them through our algorithms, and give notifications about patients that have concern or concerning trends, as noted here in orange. As you can see on the slide, we have an area called Curve. So you will get notifications that are related to labor progress. So you would turn orange, which again, early warning, please let's intervene now. Let's go assess and see what else needs to be done for this patient. If they were too slow or, quote, fall off the curve, which is labor dystocia, you would turn orange. You have parameters for vital signs that are set at whatever your facility already has as your guidelines as early warning. And then you have Qs. Qs is timely notification of concerning elements or concerning trends in your fetal tracing or your contraction pattern. Again, it's an early warning system. The idea is to provide you with timely notifications of potentially worsening conditions so you can assess the patient, intervene, and potentially avoid a delay in care. So let's take it one step further. As Alana already noted, there's several models for OB remote monitoring. The commonality is that all include an OB central command center that is remote to the L&D unit that's utilizing Vigilance. So here is the Vigilance hub over here on the left. And in this example, we have an OB central command center that's overseeing 8 sites and receiving Vigilance early warning notifications for all 8 sites. This model is being used with several of our care partners to improve efficiency in their workflows and maximize safety for moms and babies. I recently spoke with a colleague in the field. They had an experienced night shift nurse that was staying home on self-quarantine. Thus, a less experienced nurse was functioning as charge nurse. While we were talking, she had an aha moment. She was like, KK, she could be working from home. She'd be working in the command center from home because Vigilance is web-based. I said, you got it. All you need is access to your network. So when you talk about telehealth and remote patient monitoring, geography goes away. We were able to maximize their use of their human resources and expertise in their OB command center, which allowed another layer of patient safety and oversight. Healthcare organizations who utilize all the tools that technology has to offer are soon going to outpace those who choose to ignore these tools. Lastly, I just want to talk about the effect of the COVID-19 pandemic and telehealth. COVID pandemic had an enormous impact on telehealth. We had rapid expansion of covered services, and it's compelled us to rethink traditional delivery of healthcare. The Southeast Telehealth Resource Center that I'm part of saw a 500% increase in calls for assistance. These were healthcare organizations or individuals reaching out to them, needing information to ramp up their telehealth services now. Just like many of you, I'm a nurse, and it's easy to think of potential nursing applications for telehealth in times of public health emergencies, now or ones that could occur in the future. How about OB triage? What if we performed that remote and kept some patients out of the hospital setting? We have long used NST testing remotely. Think about if you were to have the impact of a surge at your facility and you start losing your staff RNs to one-on-one care of infected patients or PUIs. Your core staffing on the unit might have to be pushed above our nurse-to-patient ratios that we are used to working with. With Vigilance in place, you're going to have a layer of safety and protection to help support those nurses. COVID has caused disruptions that have forced us to look at dynamics of how we deliver healthcare. Our landscape in healthcare has forever changed. Although none of us have a crystal ball, I believe it's safe to say that it's likely our future includes a different infectious disease, healthcare emergency, or emergencies. There's been a massive shift in American mindset. We need to implement dynamic solutions to provide safe patient care as part of the new normal. Please, I beg you, please make sure that women and children are involved in those conversations going forward. Thanks again for joining us, and I am going to hand it back to Lexi.
Thank you, KK, for all the great information around telehealth. Now I'm excited to introduce Amy Fado, Emerson and RNC. She's a perinatal safety nurse from ProMedica Health System. ProMedica is a special Perigen partner that utilizes remote patient monitoring, and Amy is going to share a little about her experience. So thank you, Amy.
Sure. Thank you, Lexi. I want to say thank you so much to Alana for thinking of me and allowing me to share our little journey here. So yes, I'm the perinatal safety nurse with ProMedica. We are an 11 facility system within Northwest Ohio and Southeast Michigan. 8 of those facilities we have OB units in, and we do about a little over 7,000 deliveries per year. So like the rest of you, back in March, a few things happened for us within our system. We designated one of our facilities for adult COVID patients. So we took an entire facility and said that any COVID patient would be taken care of in that place. And that facility did include an OB unit as well. Our system incident management team developed a crisis staffing plan at that time as well. And then we had another unintended consequence of some of those decisions was some of our other low volume facilities absorbed that patient load that our COVID facility picked up and lost their normal healthy patients to those other places. So we had an increased stress load for those places that weren't used to that volume. So we wanted to maintain the focus and the pre-COVID work we have done for patient safety and not lose the focus on patient safety. So after sitting back for 5 to 6 weeks and watching what would happen in our COVID hospital, sitting back waiting for that surge to come hit us, we only had a handful of deliveries in our OB unit in that COVID hospital. So we really took the opportunity as it presented itself to us to do a pilot hub and go towards that goal that since we had been working, our journey started with Perigen in 2018 and we went with our implementation last spring, a little over a year ago. It had always been our goal to create this remote hub for monitoring our moms and babies. So we had this opportunity where all of our barriers previously essentially vanished in COVID world. And we jumped on that and essentially developed our hub plan in about a week and implemented it within our OB COVID unit to have those nurses who were no longer doing very many deliveries to monitor this hub and do a pilot period and work through some of our concerns and issues to make it a reality and a permanent hub moving forward. So We are currently in day 15 of our pilot. Our main focus, we chose to just do a little drop in the bucket and just monitor fetal heart rate cues utilizing that Vigilance hub and maternal vital signs, and really work through those processes of when to call the units and at what times and how do we script and what are the right words to say when you've got those fresh set of eyes looking at the tracings and really only seeing what's in our EMR and what's on the monitor in front of you when you can't physically see the patient. So we've really had that ability to really sit back and think through those processes. And truly what we're learning is it's just a changing culture to really be truly living that peer checking and peer coaching mentality and adjust how we treat our patients and having that extra set of eyes helping through that.
Awesome. Thank you so much, Amy, for sharing your experience. We really appreciate your time and everything that you're doing to keep moms and babies safe. On the next slide, we just have a list of resources. So when we share out the presentation, you'll have these. These are just all readily available to access. I just want to end on, we have one last poll question. And during this poll question, if you have a question for any of our speakers, you can send it in on the chat box that you used at the beginning. So I will go ahead and launch that. Just asking if you'd like to talk to anyone on our team. So whether you're a customer or you're not a customer or you have questions for any of our webinar speakers, if you just want to put in your answer there. And like I said, if you have any specific questions, you can go ahead and type those into the chat box. Give everyone a few seconds. And just a few more questions, or a few more seconds for the question. Okay, I'll go ahead and close that. On our last slide, we just wanted to say thank you. A survey will appear after the webinar and in the follow-up email. We really appreciate your feedback. If you have any last-minute questions and you want to send those in, we will answer those privately. And thank you for joining us. Let us know if you need anything. And just once again, we're thinking of you during these times and really appreciate all you're doing to keep moms and babies safe. So thank you.